So, what about the first part here? So, see, there is some structure to these lectures, believe me. Well, there's meant to be a lot, but I'm going to do each of these three things. We start with the first one. First off, we're going to look at possible distributional implications. So there's quite an interesting paper just a few years ago, Prof and colleagues, published in the International Journal for Equity in Healthcare. And what they did was a systematic literature review. And what they wanted to know is anything known about the relationship between social capital and inequalities in healthcare, socio-economic inequalities. So they did a systematic literature review, identified 60 studies, which, I don't know, doesn't seem very many, but that was 60 studies. Their strategy essentially was the studies had to be, one, about social capital, and two, must say something about socioeconomic inequalities in health. But anyway, they identified 60. And they found 56 of these studies confirmed a positive correlation between social capital, health, and social inequality. So 60 studies had to some extent gone out and looked for what sort of relationship there might be between health, social capital, and socioeconomic inequalities in health. 56 of them found some, or found a positive correlation. So that's interesting. However, only 19 of these studies formally tested for interaction effects between social capital and social inequalities in health. In other words, to what extent is the relationship between social capital and health influenced by socioeconomic inequality? And they structure their discussion of these 19 papers with respect to three different hypotheses. A buffer hypothesis, I'll explain them each in turn, dependency hypothesis, and a contextual hypothesis. So let's start with the buffer hypothesis. To quote from them, components of social capital can provide a buffer. No matter how good your English is, buffer might seem a little bit esoteric. A buffer, a sort of protective barrier. Trains, I don't know if they still do, used to have a buffer at the front, and so if they hit something, the buffer absorbed the impact. That's the word buffer here. So components of social capital can provide a buffer against stress and other negative influences on health and well-being in tightly knit communities. And so what they're thinking of here is, if you imagine social capital being measured along the horizontal and health on the vertical, what they're suggesting is possibly there really isn't very much relationship between social capital and health if you belong to high socioeconomic status group. So if you are an advantaged, socioeconomic advantaged individual, the relationship between social capital and health may be virtually non-existent. On the other hand, if you belong to a lower socioeconomic status group, it may well be that there's a positive relationship between health and social capital. Because this group benefit from the buffer effect of social capital, the protection that social capital offers. The high socioeconomic group don't need it, don't need the buffer. So that's one hypothesis. Of 18 studies that examined the relationship between social capital and health by socioeconomic status, 11 found evidence to support the buffer hypothesis. So some support there. I've got an example here. Van der Wel, judging by the name, one would imagine it would be a Dutch study, but being published in Norsk Epidemiology and being a study about the residents of Oslo. It's a Norwegian study. So they had data on almost 12,000 residents of Oslo. They had measures of social capital for 25 different administrative districts in which these 12,000 lived. So social capital was estimated from the responses residents made to a generalised trust question. So similar to the study we've just been looking at. The generalised trust question is, how much do you trust other people? A lot or little. And the measure of social capital here is an average of those individual responses. So it's the responses of people in the administrative district you're in. So Oslo is divided into 25 administrative districts, and to get the measure of social capital, you're taking the average individual level of trust in each of the 25 districts. They also had a question about participation in voluntary organisations. And what they found was in the communities or administrative districts with high levels of social capital, there was a positive impact on the self-rated health of those with the lowest income, and no effect on self-rated health for those with the higher income. So that is directly speaking to what we're just looking at here. Those with the higher income, there was no impact of social capital on health. Those with the lower income, there was a positive relationship between these measures of social capital and health. And indeed, about 11 studies came up with support for that. This has just been one example. Okay. You've got that post-lunch thing. You know, it was only 3 of us went to the Italian. The rest of you probably starved by contrast with us. I need a trolley to wheel in some caffeine for you. Right. That was the buffer hypothesis. What about dependency hypothesis? Dependency hypothesis. Again, the quote's directly, well, from the original survey paper. People with a low socioeconomic status will generally have less capital, and the amount of capital available to them cannot be used as effectively for the benefit of health. So this is back to the idea that we do see with respect to some public health programs, the groups that benefit most, in a way paradoxically, are the more advantaged groups to start with. Classic example of this is introducing screening as an option. And the groups that have high participation rates typically are the advantaged groups. The groups with the lowest participation rates in the screening program are the disadvantaged groups. Anyway, so the idea being here that in order to get the benefit of social capital in terms of improved health, you have to belong to the high socioeconomic status group. If you belong to the low socioeconomic status group, you might get some benefit. The line is positive slope, but not very much compared to the high socioeconomic group, socioeconomic status group. So they found 8 studies which looked at this that didn't find any support for it, for the hypothesis, but they did identify 3 studies that argued there was a dependency between socioeconomic, between social capital and socioeconomic inequalities. So the majority were not finding support for this relationship. Got an example here. Study that I think did find support. Which way around was it? Yeah, so it's a large US study. Now, the fact it's got 30,000 respondents, you immediately know it wasn't a study about social capital. You know, these data are being collected for something else, and then somebody's repurposing the data for this purpose. And so it's this study by Gorman, and in this large US survey, they found that the probability of hypertension, so that's, if you like, a measure of ill health, the probability of hypertension decreased with higher levels of social integration for all groups who had finished high school. So they are finding a relationship between social capital and the health measure, so long as people belonged to the more advantaged group. They belonged to those who'd finished high school. Social integration was measured by the number of specific activities they'd engaged in the last 2 weeks, such as talking to family or friends on the phone, attending a place of worship. Our sort of usual suspects: relationships with the family, religious participation. Okay. So just to summarise, dependency, there's not much evidence for the dependency hypothesis, but I've just shown you an example where there was some support. And the third hypothesis about the interrelationship between social capital, health and inequalities is called the contextual hypothesis. Social capital might benefit the better off in society, while excluding people with a lower socio-economic status or minority position. So this is even more extreme. This is an idea of social capital being good for some people, but actually more social capital worsens things for others. And it's because of perhaps the nature of the social capital is it tends to exclude others, and in that sense make their relative position even worse. That's the sort of thinking. And so here we've got it represented graphically. For the high socioeconomic status groups, strongish positive relationship between increasing social capital, increasing health. But for the low disadvantaged groups, as social capital increases, the very thing that's helping these other people, as it increases, they're getting worse off. And maybe reassuringly, they found very limited evidence to support this hypothesis. Very limited. There was this study, another large sample, again, another survey done for another purpose, of 21,000 residents, and a subgroup analysis showed an interaction with individual trust for self-reported health. So, the self-reported health was this: how would you describe your overall state of health these days? For people who reported a high level of trust, the community level trust, so that's the sort of aggregate of individual trust, the community level trust was protective of their health. So if you report a high level of trust yourself, and you're in a community where there's a high level of trust, that seems to benefit your health, a positive relationship. Whereas those people reporting a low trust score, so they themselves didn't trust others, in that situation, if there was high community trust, then that negatively affected their health. So it's an example of this sort of divergence. It is support for this contextual hypothesis. But I do stress there was really very limited support they found for this, but this was an example. Now, if you go looking for these things, you might find them. And if you've got a big enough sample size and different ways of selecting your subgroups, you increase your chances of finding something like this. So I'm not saying this doesn't exist or it's just an artifact. I'm just saying before I put much faith in the contextual hypothesis, I'd probably want to see more studies to convince me. So to summarise, we had our three hypotheses on buffer, dependency and contextual. The buffer hypothesis had the greatest support. The dependency hypothesis was a bit of support, but most studies didn't, and this one had the least support. So, in answer to should we worry about social capital from a health policy perspective because of the potential effects on inequality, the answer is, well, that might be a reason. It might be one of the reasons to pay attention to social capital.